So, Gavin, I've got a question for you.
Yep.
Guided growth.
Yep.
How useful is it in Blount's, or do we still stick on the same old principles of osteotomies?
Yeah, so guided growth, as you know, we use this for an awful lot of conditions. In Blount disease, certainly in early onset, or what some people call infantile Blount disease, we've been a bit reluctant. Why? Because it's essentially a growth arrest, isn't it? It's a growth arrest of the medial side of the physis. So if you're going to try and guide that growth, you've got to have some growth to start with. So for that reason, we've been a bit reluctant to use it. It's a different matter in adolescent onset, the later onset. There is definitely first-line treatment if you have growth remaining. But interestingly, there is some evidence out just last month, that was in June, from the USA, from Washington. It was a systematic review. And it turns out that guided growth actually is a useful technique in early onset, in juvenile Blount disease. But if you're going to do it, you have to do it early, ideally before the Langenskold stage 3. And that's quite a complicated classification. We'll probably talk about that in the course, but it's not perfect. There's still a recurrence rate after it, probably around about 25%, 30%. But then we have similar recurrence rates after osteotomy, and it's a lot less of a morbid procedure. So the answer is we should probably be doing more guided growth than certainly I am at the moment.